If you or a loved one go to a treatment for addiction or substance abuse, there's going to be two types of clinicians, therapists and counselors or case managers. Names are interchangeable. People always assume that the therapists do all the heavy lifting and just write off the counselors. Big mistake. They each play a unique part, and we're going to break it all down today. Stick around. Welcome back to the Rise from the Ashes Recovery podcast, where we blend lived experience with clinical expertise to give you the raw and real details into the addiction and mental health recovery process. Be sure to follow us on X at RFTA Recovery and share your thoughts on this episode or your lived experience with the topic. As always, this podcast is for entertainment purposes only. It should never be substituted for official clinical or medical advice. One of the most important nuances that can make or break someone's recovery experience is the dynamic between therapists and counselors when you go into treatment. Like I said previously, everybody assumes that the therapist does all the heavy lifting and the counselor just kind of sits there and does nothing. And that's absolutely the farthest thing from it. This oftentimes serves as the first experience where individuals experience the problems that this podcast is attempting to rectify, which is the disconnect between the ivory tower of academics, evidence-based treatments, and the claims to be the pinnacle and panacea of all treatment and the know-alls, right? Versus the more grassroots, lived experience, heavy, you could almost say 12-step-y, classic forms of substance abuse counseling, right? They both have their place, and we're going to get into it today with somebody who has the authority and the experience to say so. All right, so I've got Matthew Beck with me today, who is a licensed marriage and family therapist, coming up on 11 years sober, got his career started working in the chemical dependency and mental health treatment field, and then eventually found his passion in supervising those in treatment for clinicians and counselors and all that stuff. So, Matt, take us back to the lowest point. What got you into recovery?
Well, hello, Bryant. Good to see you, and welcome to everyone in podcast land. So my story, I used for quite a few years, all different types of substances. I started drinking when I started smoking marijuana shortly after, started taking benzos and opiates in my teens, and just progressively got more destructive over time. So I just ended up in hospitals and in institutions, as they say, and I just hit a point of no return. I had lost the trust and faith of nearly everybody in my life. I was just going to go to the bitter end, and I decided to fight back, but it took a little.
So back then, was there anybody that you leaned on or anybody in particular that really made the difference when you talk about your recovery journey?
My family really wrapped around me. My cousins, my brother, they all expressed concerns. I denied, of course. People around me, friends in my life, all expressed their concerns. My drinking and using was getting out of control. I was becoming more destructive, and I think that just having them in my life to give me, some direction. I just kind of had this, let's say, an epiphany through the urging of my friends and family, just kind of opening the door to saying, what am I supposed to be? And I was really I guess I just needed to get to a certain level of willingness to do whatever it takes to get that life that I wanted.
When you finally got to that place where you had the willingness to do all that stuff, to finally take the next step, get sober, do your thing, did you do so via treatment programs? Did you do so via the outside recovery programs like 12-step or otherwise? What was your approach?
I ended up coming to treatment, and I went to treatment in California, Southern Cal, and I was definitely resistant. I wanted to go right home. I wanted to believe that these people didn't know what they were talking about, right?
We never do. We make it up as we go.
Don't you know who I think I am, right? I guess you don't know me too well, right? And I'm going to show you how smart and how talented and how much I actually know, right? So the ego it comes back with a force when you're cornered sometimes, and that's why when we talk about willingness, you have to be willing to concede to my innermost self that I can't drink, I can't use, I can't live the life that I've been living successfully because it's driving me to an early grave, essentially.
When you're in there and you're resistant and had all the answers and yada, 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 which is a very common thing in recovery or in treatment anyway, I'm assuming that you did have a counselor and a therapist when you were in treatment, because that's the general structure that we're going to be talking about today. What was that dynamic like?
Well, of course, I came into treatment, and my case manager, who I still communicate with even 12 years later, just a big, boisterous guy, big personality, got everyone's attention. And I don't know, I took a liking to him. I was like, he's kind of, it's amusing. But when I was in session with him one on one, he went from being this kind of endearing, warm person to connect with to this. Now, let's talk business now. This is one on one time. Okay. Yeah. Like, we're cool, but I'm here for your life. I'm here because you're going to lose your life. This is life or death. You need to know this. Because if you don't know it, you might lose yours, and it's like that reality. I needed to get struck with that reality from someone, but I also needed to get to like a level of trust with them, like that I knew that this person was out for my best interest before I opened my ears, right? And that's probably, so I think a great counselor, if you want to, because I think that's going to be, like you said, that's going to be our overarching topic today. A great counselor, right, starts by developing a rapport, a connection, connecting piece between the counselor and the patient. It's like, I see you, right? I don't judge you, but I'm gonna give you some direction here, because I do care about you, and it might feel like tough love sometimes, but that's what it is.
This is the real meat and potato stuff, because I know me and you have worked together at other facilities. When we talk about defining the roles, because I think when you talk about therapists versus counselors, I think defining the roles, the very first thing is off the bat that, of course, therapists typically have the higher levels of education. They typically have a master's degree. Now, granted, when you're master's level clinician in working in a treatment environment, oftentimes you are at an associate level where you're collecting your hours, and that's by no stretch of the imagination minimizing their competency or abilities. It's just to say they are newer to the clinical field, I guess you would say, versus a counselor. On social media and the internet and everywhere, everyone always wants to shit all over the counselors. They always want to say, oh, they just have a certificate or whatever it is. They don't have the education, and they really discredit them. But like you were talking about in your experience, is that counselors play a very different role. And, educationally, depending on where it is, I know back when I was getting my stuff way back when, it was a 60 unit college class out of college where you had, 2,500 hours of intern hours and you could only get 2,000 in a calendar year. It was a very extensive process. It's not like I just got a weekend seminar and got this thing. It took some time, but there are ways to get them that aren't as, taking as much time. In your eyes, how would you define the roles between the two, between therapist and counselor?
Yeah, so great question. And, drawing upon my experience to give you that comparative kind of analysis there, right? So my counselor was the directive, tough love, but the therapist, in turn, my therapist wanted to help me explore the things about myself that I already knew, but that I wasn't willing to look at. The things that I was either consciously or subconsciously pushing down, pushing away, avoiding, using maybe some types of defense mechanisms to avoid looking at the true nature of things, right? And I think the therapist then remains objective, not as directive, and helps the patient discover things within about themselves that they are already aware of, but that they're not looking at.
Right.
That's the skill. I would say, like, we're not there. A great therapist is not a wizard or a genie or something drawing with a magic wand, something like, I'm going to give you some great advice about how to live your life. No, a great therapist helps you to look at things that you're not looking at.
Right.
And a
Exactly.
great counselor brings that to the table and addresses it directly. Your life is affected in this way because of this approach, because of this perspective, because of this way of experiencing it, or your response. It's having this result. It's not working. Let me
Yeah.
step in and give you some feedback on what might work. But the therapist doesn't do that, right? So this is why it's
Right.
like it's a collaboration. It has to be. And I think
Exactly.
every great treatment team meeting, every clinical supervision meeting, every time we talk about patients, we should have the therapist and the case manager present. We should always hear both perspectives when we do case analysis. When we talk about these clients, I want to hear both perspectives because they are dynamic. What they're doing is totally different.
Well, I'd
Yeah.
say there's another layer to this that I feel like doesn't get enough attention when you talk about in the social media recovery space, right? Is that when everyone knows when clients come in, obviously substance abuse is going to be that main focus. 99% of times co-occurring mental health that goes along with that. We all know that. And when a client comes in, we have a very specific job to do. And if I might add, our backs are against the wall when it comes to time, because the reality here is that we just don't have enough time. We are doing a big job with very little time to do it in. So we don't have a whole lot of time to mess around. But, you and I have been on cases together where, I'm not going to speak to any of those specific cases, but as an example, right? The client comes in and has been cheeking medications in the office, and this is becoming a problem and someone has to talk to him about it. You have the counselor and you have the therapist. And obviously the therapist, like you talk about having that therapeutic alliance, having to work on some of that deeper stuff, can't always risk that. So someone's got to be the one to talk to him. Typically that comes
Yes.
to be the counselor, right? I usually break it down to why versus how, right? Is that a therapist might be very big on the why, whereas the counselor is going to be more leaning towards the how. Would you say that that's accurate?
Oh yeah, absolutely. I also think that the counselor is also like um, responsible for helping these patients develop like a toolbox to address the why and the how, right? To support the what goes on after this. How can we create a plan for after this that's going to be most effective? Not just what's going on in the moment, but what's going on after this, and how can we improve the prognosis that you won't continue to be coming back to treatment like a revolving door, right? The therapist plays a small role in that in general, from my perspective and my experience, right? They're in the here and now, like you're talking about, right? But you not only the counselor has a tricky job because it's I'm going to be calling to helping them get their FMLA set up as I'm getting their aftercare plan set up for their outpatient program, and
Right.
also addressing such a variety of it's complex. And I think that the working partnership between a therapist and a counselor, that it's not only is it best practice, but I feel like when there's not a strong working partnership between a therapist and counselor, it's not necessarily the most ethical treatment. I think it's an
Exactly.
obligation for us to communicate with each other,
Right.
you know?
And that's why I wanted to have you on here, is because the topic of what makes a good therapist and counselor within treatment is one of those topics that it's hard to get the truth from people who are actively doing it in that moment. Because the politics, right? I'm having this conversation with you because while you work with a lot of different facilities as far as supervising their clinicians, that is primarily a lot of the job that you have. So you're not invested into the politics of the business. And it's hard because the therapists that are there, and especially when you talk about the battle between admissions and clinical, and you and I both know that bigger than anything, the admissions is saying, oh yeah, come on in, the clinicians, and they'll do this for you, and they'll do that for you, and da da da. And then they get in, and it's a whole other ball game. And you were talking about aftercare planning, all the logistics and things like that, because that's another thing with counselors. People think that they are just like a secretary. Make me this appointment, do this for me, blah, blah, blah. And it's actually more than that, because as you and I have seen many times, a client's family might say, you know what, you're not allowed to come home. That's what it is. And you have to figure that out, and they'll help you do all that. So on one hand, in one fell swoop, you've got somebody who's got to tell the client, hey, parents say you're not coming home. B, where are you going to go after this, or what are your options? And C, then the emotional fallout and impact that comes along with all that with one little swoop. And that's where I feel like the dynamic you discussed of the tag team between therapists and counselors is what makes it ethical and improves prognosis.
Yeah, absolutely. These types of things happen in a moment too. Sometimes client A, their insurance just dropped them, and so tomorrow is their last day. And you make that call to
Right.
the parents, and they're like, he's not coming back to Ohio. And then
Right.
now you have to break the news to them. Not only are they not going home, but they have to leave tomorrow. And we're going to figure out an outpatient program for them to go to, where they don't know their therapist, their counselor, their other patients that are there. They don't know where it is. They don't know what kind of quality of living it's going to be. It's like it's a day's notice. And this is, well, I mean, see, again, you talk about the battle between clinical and admissions, and I talk about like between what we're trying to do and the insurance companies that are telling us, okay,
And then there's that too. Yeah.
you have one more day and figure out what to do. But we
Yeah.
also expect you to give these clients the highest quality of care. But you
Yes.
have one day.
Yeah. Well, and that's what I
Or,
was saying about our backs against the wall is that the game sucks.
yeah. Yeah, so I guess what came first, the chicken or the egg? Because it's like, everyone can point fingers at each other, like the Spider-Man meme where they're all pointing at each other,
Yeah.
and it's like,
Yeah. Exactly. Yeah.
I don't know who's to blame, right? I know that the
Right.
clinicians aren't to blame. We just, like I said, when I'm with my supervisees and with my counselors and case managers, Brian, this is what I always say, okay? And I have lots of interns, lots of associates, lots of case managers and RADTs and KDACs that I work with. I always say, put your clinical hat on when you walk through the doors and utilize your skills to the best of your ability. All the things that you've been taught, everybody in that space that needs that, give it to them to the best of your ability. And when you walk out those doors, take the hat off, leave it behind you, and go be Brian again, and go be Matt again, and go be, right? You need to just bring the skill in there. And so when you can look at it that way, it's like tomorrow when I go in, I don't know who's going to be there. I don't know who came, who went, how they got there, why they left, what happened. I'll do my best to figure all that out. But my focus when I walk through those doors is who's there today. And my focus is going to be using the skill set that I have to help the people that are there today. And again, when I leave that day, I'm handing it off to the next people. And they're going to care for these patients now. And I'm
Oh,
going to go be Matt.
yeah. So being a supervisor, right? And especially, I would say that this is more prevalent when you talk about with counselors than it is with therapists, but I feel like it's the same. I feel like the counselors, it's much more prevalent for them to have had a personal journey in recovery and or some kind of lived experience component with that then prompts them to go into becoming a counselor. So they've already got the lived experience component and they're trying to beef up their, say, clinical expertise when doing all that. Where I feel like the therapists, generally speaking, the ones that I've always interacted with typically don't have that background. And so while they might be academically coming in from a place where they professionally and clinically are trained and educated, there's a learning curve that comes along with working with this population. What is your feelings and experience when you talk about the role of lived experience within your either therapists or counselors or whoever else?
It's such a great question, Brian. So I'll talk about the differentiation between maybe a therapist who is in recovery and a therapist who is not, and some of the general things that I've noticed with the, many, many associates I've worked with now. I think it's level of expectation. I think that's really important that someone who is in recovery, who has had that recovery journey themselves, understands what it's like to go through it personally. It's how difficult it is, how some days you're just hanging on by a thread, it feels like, and you just
Right.
want to get through the day, right? And unless you experience that feeling firsthand, you can't really explain it. So what I try to do with therapists who, and by the way, my therapist that you brought up earlier, my experience, she was not an alcoholic or an addict, right? I don't say the word norming because I don't think anybody sets the bar or defines what normal is. So I
Normal
would
is
just
definitely
say,
relative. Yeah.
yeah, so not non-alcoholic or addict. And she's the one that gave me the prompting and the encouragement to get back into graduate school to get my master's when I was 9 months sober. So like I give her all the credit in the world. She helped me, So that being said, I want to make sure I'm making it very clear that I don't think it matters for the most part, but I think it's important for the non-alcoholic, non-addict counselor or therapist to understand that the expectations that they have, that they don't have a full understanding of what it's like to experience what the patient is experiencing, and that the expectations sometimes are just help them get through the day. I see a
Right.
lot of therapists, they're coming in and we're like, well, they're not engaging in therapy and they're not digging deep and they're not looking at their core issues and they don't want to write letter to their inner child. And I was like, well, sometimes these patients come in because they just want to get off the street. and they
Yes,
need a bed to
absolutely.
sleep in, and they need a meal, and
Yeah.
maybe they'll hear a few things while they're with us that'll stick,
Yes.
right? But
That's such a vital piece too.
sometimes
Yeah.
sometimes we just need to be okay with that and lower the bar that you're setting here. Just like sometimes we're here to just keep them going, to try to give them some insight and to help them keep going, bring them back from the abyss. That's it.
And that's a reality that I wish wasn't true, that I wish I could help the public understand more, is that the mere fact that somebody has gone to treatment in and of itself does not mean that they are ready. And it's an unfortunate reality that we do wish isn't true, but it's the case. And you're absolutely right. Having therapists that come in here, and I think, I don't know, maybe you can tell me what you think, but I feel like graduate school and all these other things conditions their therapist to believe that their client is at the respective stage of change that would actually allow them to do the work that you're trying to do with them, like inner child or, whatever it is. It doesn't really matter. That it conditions them, the clinician, to think, oh yeah, when I have a client in front of me, they are automatically in that working action stage of change. I can go here and they're going to meet me there. And that's a learning curve that I feel like new therapists coming into the field have to learn one way or the other.
Just every patient has a different way of expressing themselves. We need to tap into that type of expression, whatever that may be. Anybody that achieves a high level of success in this field, right, is likely has quite a bit of perfectionist qualities, right? Your KDACs, your KDAC 2s, your 3s, your master's level clinicians, right?
Right.
These are high achieving people. And so what happens is individuals like this, we tend to develop, or individuals like this tend to develop these unrelenting standards.
Right.
And it starts with these unrelenting standards on self. It's like, well, standards on standards, and I'll never get to quite where I want to be. I'll never be quite enough as because it's this perfectionist thing that won't go away. And part of it is a driving force for excelling in the field, excelling in your career and your education and training. But the issue with that is sometimes these unrelenting standards will transition them onto the patients.
Yes, absolutely.
And I was like, well, how come they're not doing this? Or they should be more responsive in therapy. Or,
Yeah.
right, how come they're so resistant? There's something wrong here. There's
That's where
something
the
wrong
counselors
here,
come in,
right?
right? If they have that lived experience background where, say, they got sober, and let's just take a 12-step culture, right? It's very action oriented. It's very, I will know what you believe based on what your actions are. And so, clinician or anybody else is in that place where they're coming from a lived experience, 12-step background, goes to the education, becomes a counselor, and they're going in with that expectation of saying, okay, I'll know if the client is willing or able or whatever it is based on their actions. And if they don't do shit, then they don't want it. And then that's where that more confronting comes in, which, to be fair, I'm giving a very overgeneralized statement, because I do think that, like you were saying with your own personal story, right? There's resistance, there's the I know everything, there's a degree of conflict that comes along that I think is healthy for that specific counselor. But when you talk about expectations, like you said, clients will express themselves differently, they'll learn differently, they'll do all these things. And when you come from a background of, say, 12-step culture, it's hard because you have to now learn new ways of seeing people in their own experience.
Again, to me, that's the secret ingredient, is when we see the resistance to the counselors and the therapists, the frustrations that come up. Someone who is in recovery understands that that resistance comes from a place of fear, comes from a place of insecurity. And the fear and insecurity to me is the fear of being alone and the insecurity around not feeling seen fully. When that person, as a person in early recovery, then when someone comes into their life that's like, I do see you. I do see you. And I don't judge you. And I've been where you are, and I'm here now. I reflect on what changed within me is, I was resistant, and I think a couple of my peers encouraged me to listen to some of these guys who have time. And in the beginning, I'm like, fine, I'll put in my headphones and I'm sitting in the back, and I'm like, whatever. But I started inching closer. I saw my friends inching closer, and I was like, what are these guys going to teach me? And eventually I started listening a little bit. I heard a couple of guys who had some real wisdom and some life experience and some success in their lives. And I was like, okay, let me talk to him. I'm gonna go talk to this guy, and got a coffee with him. And I was like, okay. I think it's important for the addict and the alcoholic to meet like-minded individuals, to be able to speak with
Right.
someone who can relate to the condition, talk about the condition, right?
Right.
I know that alcoholism is not about the drink. It's about what goes on in here and in
And
here.
that's something that takes a while for people to figure out that itself too. Is just exactly what you said right there, is the whole setting it down. That's the easy part. It's all the other stuff that is really the pain in the ass.
And so when you get someone that you can connect with, and you just got to try to find that person or people, and you can share with, that person that you can share with, and say, they do see me, they don't judge me. I can share these alcoholic thoughts with this person, and they won't look at me like I'm a crazy person. They'll say, that sounds pretty wild, Matt, but I get it. But here's how you should address that. And let me show you how to get there. There's a power in that that's immeasurable,
Absolutely.
paramount. That's it.
Absolutely. Well, and I'm sure
So
you've seen it with your education and stuff too. I know it was shoved down my throat being in school that a clinician does not need to be an addict or an alcoholic to be able to work with somebody who is an addict or an alcoholic, right? And that is technically true. However, I would argue that because we're working against the clock and there's that internal piece that you talk about right there with how that, call it connection, call it being seen, whatever it is so vital, that I would argue that having at least one of the two clinical members being somebody who's in recovery is important, because when that client walks in the door, you've got you're back against the wall. You've got an impossible job to do with very little time to do it in, with all the baggage coming in there. And that one thing serves as the bridge between clinician and client that builds trust and rapport like that, without needing to go through all the hoops and stuff. It saves so much time and it gets you there quicker, faster when you don't have much time to begin with.
if you want to summate that whole idea, right, is that we look at the counselor can be more directive and more subjective, because like you said, whereas most of the therapists that you've met are not in recovery, I know I'm an exception. Most of the counselors that I've met are in recovery.
Right.
So almost the exact opposite, actually. So I would say the counselor can afford to be more directive and subjective in their approach because of the shared experience, maybe.
Right.
There's a piece
Exactly.
there. There's a piece there. And the therapist maybe will be more objective and helping the individual draw out of them, right, and come to certain insights on their own, because for the most part the therapist doesn't fully understand what the client is experiencing. They're trying to help them understand what they are experiencing. So in a way it's almost like a perfect separation in a sense.
Exactly. Well, it's
You have
tough
this
too because
objective and a subjective and objective, if you want to just break it down, really, right?
right.
So yeah.
Exactly. And I think some of the frustration that comes in, and I think it's mutually shared by everybody, is like I said, people come in and we don't have time. And I know this was my frustration back when I was a counselor doing all that stuff, until I went further on in my education and career to have a different understanding. But I would get frustrated when I would see therapists who were able to take what seemed like a more lackadaisical approach to something, like like, oh, hey, well, they're not there. And, today we didn't get there. And, here's where they're at emotionally. And I'm sitting there like, dude, they were sticking meth in their neck and smoking fentanyl a day and a half ago. They're on their last leg of insurance. They've been to 20 treatment centers. Everyone's done with them. This is it. We don't have time to just say, oh, well, we didn't get there today. And that, I think, is a big frustration that I think is shared by not just the clinicians, but it's also the family members who send their loved ones to treatment or do all those things. Is everyone's going, come on, come on, come on. And finding a balance of that push and live and let live is challenging for everyone, I would say.
It sounds like there's a lack of urgency in a sense, but I'm laughing because well that is how the therapists are trained by the universities and the schools, and those are the basic building block skills that they're learning at that level, right? But essentially, I think it's important to find yourself in the work and bring yourself to the session so that you can make an authentic connection with your patients. I think counselors are afforded the opportunity to do that more than therapists are because the training that a therapist has is so firmly into don't push them. You don't want them to have transference about or negative feelings about you for the next session, that you were trying to steer them in a direction that they didn't want to go. And then now whenever they see you, they get, oh, this is the one that tried to get me to talk about this thing that I didn't want to talk about. So now I'm not going to go to session next time because I don't want them to bring this up again. So it is like a slippery slope, right?
Yes.
But at the same time, as a therapist in recovery, the directive side of me comes out from time to time because I understand on a personal level that this is life or death because my life was spared. Right. I'm very lucky to be alive. You know, it was another trip to the hospital that brought me out here in the first place. So when I see a patient who maybe has had so much trauma, feels so broken, so insecure, so broken down, feeling abandoned. They want to give up. I will pull out more subjective feedback as a therapist, and I think that because of my history, right, in certain moments, I will allow myself to say, John, I hear this is happening right now, but here are my concerns. And I'm telling you this because I do care about you. I don't want to see you leave this session today and have you go from here to here.
Right.
And my concern is that if you continue A, B, and C, that this is gonna happen. I will give feedback about my concerns.
Right.
I will, but because I think someone in recovery recognizes the sense of urgency in certain moments, like when someone is on the verge of AMA, or they're so caught up in their head about wanting to use or drink, and you know that if you don't take the right approach in that session, that they can very well leave that session, go hurt themselves or another person, right? So at that point, uh, a, a therapist also, I think, needs to understand when to put the objective aside and say, this is like life or death. This is high risk situation. I need to give feedback here. I need to step in. So maybe, Brian, going back to your original question, someone who's in recovery can sense that urgency, right? Is more attuned with it than someone who hasn't.
Absolutely. Well, the person who's had the lived experience, it's something that you can't teach, right? It's a look in their eye, it's a vocal tone, it's the way they carry themselves. It's like, they're getting squirrely. You know what's going on inside their head, probably because you did the same exact thing, or you were around just a bunch of people in the past who did that, and you can spot that a mile away. Now, you did bring up another interesting thing, which I think is important to touch on. Having the therapist allow themselves to be human, because I call them the that's interesting therapists. They come out of school and yes, they are taught to be objective and to sit there and allow things to happen, but they're so terrified to be a person because it goes against their training to a certain degree, and therefore that means that something will have affected them or whatever, that they just do the that's interesting. I would argue, specifically with the substance abuse population, they deal in lies and deceptions all the time. And they know when the person they're sitting across from is being dishonest, disingenuous, or inauthentic of some kind. They have a radar, they can spot it a mile away. And so when you have that therapist that comes out of school, it's not like they're doing anything wrong, but they're so afraid to be them that it can turn the client off, even if they're not doing anything wrong per se. I mean, and I think that's what you were saying about that, setting aside the objective to be more subjective, is allowing that to come out. What do you think about that?
I just feel that therapist and the therapist in training has their own fears to overcome and their own counter-transference to overcome. Am I going to say the right thing? Because remember, one of the legal requirements is do no harm. And I feel like therapists in the early stages get so caught up on, I don't want to introduce something that's going to hurt them. I'm so terrified of inflicting more pain or saying the wrong thing or not doing the right thing here. And I guess I think you hit it right on the head, is just make a human connection with your patient. Let them understand that you have their best interest in mind, that you're out for their best interest, that you're aligning with them, that we're going to do this together. We're not going to get it right every step of the way, but I got you, right?
Exactly.
And it's like, and it's not going to go perfectly, but I think we're going to gain a lot of knowledge. We're going to gain a lot of insight into what's going to be best for you in your life. I think that a therapist in their early stages is struggling with imposter syndrome and feeling like, well, am I even good at this? What am I doing here? I went right from a classroom reading about modalities, and now I'm in front of this client, and am I even good with this? Am I a fraud? Right? And the truth is, the university does a wonderful job teaching about the modalities and the technical skills, and right. But a client doesn't want to work with a robotic approach.
Right.
They don't want to work with a modality. They don't want to work with the technical skills. They want to work with Bryant. They want to work with Matt. So who's Matt? Is Matt someone that I can talk to? Right. So I always say, like, with students are like, well, what modality am I working on? I was like, well, the goal is to go from a cognitive behavioral therapy process to Bryant's process, or an experiential therapy humanistic approach to Matt's approach.
Yep. Exactly.
And those approaches are combinations of all of the modalities that we've taken into our approach.
Yes.
Fair enough? Yeah.
Absolutely. And I think that I know for me, when it came to as my education and experience and technical proficiencies increased, I was always at least grateful for that more recovery based background, which then went to substance abuse counseling, which then went to therapy, because as the modalities came out, allowing yourself to be you, like as an example, as a therapist, I'll cuss from time to time. I'll, speak the language about some of the shit I used to do. I don't think that that has any bearing on whether that makes me a good or a bad therapist. I just don't. But it's one of those things where, and I've had clinical teams before that I've managed, and I've had new master's level clinicians that are in there and they're talking about trying to connect to the client, blah, blah, blah. And it sounds dumb, but I'll tell them, like, hey, throw in a few fucks here and there. I'm serious. Just do a little bit. It sounds so dumb, but those little tiny things will make the client in front of you go, oh, I have a human in front of me, especially depending on the background that they're coming from. It helps so much.
I love it, Brian. And, I'll throw another little, so the office is intimidating for them.
Yes,
right?
absolutely.
So if you're in person, don't sit behind your desk.
Yeah.
Pull your chair around your desk. Meet with them. Nothing, no barriers. I'm with you, right? If it's a beautiful day and it's possible, can you go for a walk? You have privacy. Can you go for, side by side, no uncomfortable eye contact, two people walking side by side, having a conversation about life. I'm your therapist, you're my patient. We go find a private place in the park. Let's have a discussion. One human being to another.
Absolutely.
Right. Clients don't want to open up about their core issues in those early sessions. Whatever. Talk to them about Game of Thrones for 40 minutes and then ask them about what their favorite characters are and why they're drawn to those characters.
Right.
You're a Cersei fan? Are you kidding me? Okay, wow. What is it about Cersei? Brian's laughing because he knows
that's right. I forgot you love Cersei. I forgot about that. That's right.
And I was like, she's just fighting for her family. No, I'm just but it's like, you are okay. Well, tell me more about, like, what is it that draws you to that character? Any great music, any song lyrics that have really connected with you lately? Any music? I have no idea what kind of music you're listening to. You're 20 years old. Play me some song lyrics. What does that mean to you? Talk to me about this. Movies. What characters? What do you relate to? Get to know them.
And I think
Okay,
it's
we're not.
important for the listeners to understand too that, because I feel like it's natural. Like what you're just talking about, like, hey, you like Game of Thrones? Tell me about Game of Thrones for 40 minutes and then explain to me all this stuff. It sounds to somebody who doesn't know anything about clinical work, it would sound like you just bullshitted an entire session. But I know what you're talking about when you say, hey, listen, the things that we're working on are deeper. So, like, as an example, right? There's a thing called secure base priming, which is basically when the therapist steps into the role, I'm greatly paraphrasing, of basically the parent and gives like those attaboys or whatever it is, but obviously in a professional and healthy manner to then basically have the client healthily attached to them. And that is a part of the process to go through that whole thing, right? And that means that what you're working on in that aspect is their attachment. And yes, practically, we talked about Game of Thrones, but that might be the vehicle. And I know for me, this last time that I was in treatment before I got sober, and the person that I'm talking about, my therapist, in hindsight, she did nothing for me clinically other than one thing. I walked in the door hating therapists because of a bunch of life shit that had happened, and I had a bunch of really bad ones. Her main thing was I left the office going, hey, maybe they don't all suck. And to me, that was the mainspring of a lot of other work down the road. But in that moment, practically, it didn't do anything. The case manager was the one really pushing me in other areas.
Right. I think it's by helping draw out that common interest. Now we can talk about, well, do you agree with Daenerys's motivation to attack the village like that? What do you think was her reasoning behind that? Like, I'm now understanding their philosophies, their ideologies, their way of seeing the world and its people. So important. The way, not only the way they see themselves in that mirror, but the way they perceive and experience the world and its people through that vehicle. Now I'm getting to know them, right? And with self disclosure, I'm not going to say, oh, I totally agree with you. I'm so glad she slaughtered everyone in that town. But I'm going to be like, that's interesting. What do you think that means in the big scale? What do you think? Why do you think you see it that way as opposed to this way? Now we're digging deep. Where did that idea come from? When you were a child, this happened and that happened. Your mom and dad told you this and that's why maybe right now we're drawing connections eventually to these places.
You touch on one quick thing that I think is important to mention too. Views around self-disclosure, because I know classically trained therapists in many ways are taught pretty much don't ever disclose anything as much as you can, because then you're putting the focus on you, right? And people that come from a more grassroots recovery background where it's all about self-disclosure, I would argue that both have their place in that. I call it strategic self-disclosure, right? Like when you say, hey, what do you think about Daenerys, doing all this stuff? Hell, if I'm the therapist, I would have looked my client dead in the face and been like, I think it's fucking awesome. That's just me. I saw it coming. She's the mad queen. It's happening, right? And I do that because, again, it's that authenticity. And the thing is that especially if I've got a client that doesn't want to talk, if I can strategically self-disclose just a little bit, that makes them then all of a sudden engage and do all that stuff. Dude, who cares if they know a little bit about me? But anyway, what do you think would be, when someone's going into a treatment, what do you think they should look for in a therapist and counselor? So both of them.
Okay, when someone's going into treatment, in a therapist, you want to find someone who is engaged, who you feel that has some type of empathic connection with you, that can understand what you're feeling and experiencing, right? That can be present with you, and someone that can provide some type of gentle healing when mental health symptoms or fears or anxieties or depressive symptoms are coming into play, that these are the individuals that we go to for peace and healing and de-escalation and quiet time and getting back to a baseline, right? That's what I want in a therapist. And with a counselor, I want someone who is going to hold me accountable and responsible, right? That's going to have some type of unconditional positive regard for me, but also some tough love. Tell me what I need to hear, not what I want to hear, right? And yeah, I think that would be, those would be the main things I would focus on.
Well, Matt, as always, thank you very much. Love the conversation and
Thanks, man.
very much appreciate it, bud.
Great to see you, man. We'll talk soon.